And it is our greatest pleasure and honor to have the representative from Ministry of Public Health to be with us today, Dr. Surakhamet Mahasiri Mongkol.
Good morning, everyone. My name is Surakhamet Mahasiri Mongkol. I'm working as Director of Genomic Medicine and Innovation Support at Department of Medical Science, Ministry of Public Health, Thailand. Today, I'm going to share with you about the initiative called Genomics Thailand, which is a collaboration between ministries, the Ministry of Public Health, Ministry of Education, and the Ministry of Science and Technology. And the Ministry of Education, part of it, and the Ministry of Science and Technology is combined to the new ministry. So now this is the two ministries collaboration plan. And I would like to give you some background of Thailand. Thailand demographic data and health system and the pharmacogenetic test is the cases for pushing this national plan forward. And I show you some case study of genetic test implementation. And finally, I discuss about the Genomics Thailand National Action Plan from 2020 to 2024. Thailand is the a nation with around 68.8 million populations, and we have the life expectancy at birth around 75 years. And we have the low fertility rate. So in the next 10 years, Thailand is going to be a fully aging populations. A lot of the Thai people will be over 60 years old. And that is the big problem in Thailand in the next decade. The Thailand's public health insurance schemes is covering by three schemes. The first scheme is the Civil Servant Medical Benefit Scheme, which is established by Royal Decree in 1980. The Comptroller General's Department, Ministry of Finance is the main administrative office for this scheme. It is covering 4.4 million populations. Financing came from tax-based, non-contributory financings. The budget is open-ended, and it is covering majority of the civil servants and their relatives. I am in this scheme, and all the civil servants will be under this scheme. The next scheme is the Social Health Insurance Scheme. This is established under the Social Security Act 1990. It is administered by Social Security Office, Ministry of Labor. It is covering 10.6 million populations. And the source of finance is the tripartite contribution from the government, the employer, and the employee themselves. The budget is closest-ended budget, and they pay based on the per capitation and for the inpatient, they paid it by drug-related group coding. And the last scheme is called Universal Coverage Scheme. It is administered by the National Health Security Office under the National Health Security Act 2002. This is covering the majority of Thai population at 48 million. It is similar to social health insurance scheme, but because of the size of the budget, this is more aggressive in terms of introducing new technology, and they have some part of the payment as the fee schedule for specific high cost procedures. Genetic test is usually introduced first by the civil servant medical benefit scheme, and then the universal coverage scheme, and then the last, usually the social health insurance scheme. So that is the overview of how we get universal health coverage in Thailand. For the pharmacogenomics implementation cases in Thailand, we are focusing on the genetic test to prevent Stevens-Johnson syndrome and toxic epidermal necrosis. This is the report of SJS10 in Thailand around last 10 years. And the first and the most common drugs that cause Stevens-10 in Thailand, Stevens-Johnson syndrome and 10 in Thailand is cotrimoxazole. It is used to treat the opportunistic infection in HIV-infected patients and also the melanoidosis, which is common in the northeastern of Thailand. And the second most common drug causing SJS10 in Thailand is carbamazepine, which we already know that HUB 1502 or HUB 75 serotype is the genetic risk factor for these adverse events from carbamazepine. And the third most common drug causing SJS10 in Thailand is allopurinol. And we know that HUB 5801 is the risk for SJS10 from allopurinol. These two pies is color-coded because we had genetic test and we can implement it at the national scale, and we can eventually prevent almost all cases of SJS10 from carbamazepine and allopurinol if we avoid these drugs in those at risk by genetic factors. We had the brainstorm meeting in August 2009 to establish the way forward to introduce this pharmacogenetics test implementation across Thailand, and it was very supportive from the clinicians, the dermatologists, and the neurologists who use the drugs. And the first drug that we try to introduce is the HUB 1502 for carbamazepine-induced Stevens-10 prevention. HUB 1502 is a very common variation of HUB in Southeast Asian population. It is around 16% in Thai population, and in Indonesian is around 22.9%, and it was virtually absent in Japanese and US population. And this is very interesting phenomenon because the SJS10 from carbamazepine is rarely reported in Japan or in the Western country, but in Southeast Asia it was very well known for a long time that our population has high risk to develop SJS10 from carbamazepine. We at the Department of Medical Science developed the test kit for HUB1502 typing. It was awarded National Innovation Awards in the 2015. The kits enable the lower genotyping cost, and we can implement these genotyping techniques across the regional laboratory centers. We also develop the test that discriminate HUB15, HUB1301, which is the common false positive allele for HUB1502 kit in Southeast Asia. So this kit is cheaper and better at the better accuracy for identifying HUB1502. It took us around 14 years to introduce this HUB1502 testing for preventing Steven from carbamazepine under the Universal Health Coverage Scheme. In 2004, the Taiwanese team published the first discovery of these genetic risks in Taiwanese population. It was published in Science, and it was well accepted by many researchers that this genetic risk is the most promising pharmacogenetic test to prevent adverse drug reaction. Based on that finding, it took us 4 years to establish the case control study in Thai population. This is done by Professor Wichita Tatsani Yakun at the Konkan University. So her team collected Steven case from carbamazepine and those carbamazepine tolerant controls from the hospital data, and she genotyped the samples and found that HUB1502 is strong risk factor for carbamazepine-induced severe cutaneous adverse drug reaction in Thais. And the next year, we submit the evidence to the National Health Security Office for them to consider HUB1502 testing into the Universal Health Coverage Plan. The NSSO asks for the health economic evaluation and the introduction of this test into the national clinical practice guidelines, and the feasibility of doing this test across Thai populations. So we funded the health economic study for evaluation of HUB1502 genetic test to prevent carbamazepine-induced scar. It was done by Health Intervention Therapy Assessment Program under the Ministry of Public Health. It turned out that the health economic evaluation is good for this test, especially for those who need carbamazepine from trigeminal neuralgia, and it is less cost effective for people who start carbamazepine from epilepsy indication. We also did the pilot study in Bangkok by providing all patients that need carbamazepine the HUB1502 genotyping service. In the pilot study, it is proof feasible for us to genotype all patients in Bangkok for HUB-1502 testing. The number of tests is around 1,200 cases per year in Bangkok. And the guideline for epilepsy was modified to introduce the genetic test of HLB-1502 before carbamazepine initiation. And we also collaborating with the Malaysia and Indonesia research team to do health economic study and genotyping the Malaysia-Indonesia population. And eventually the test was introduced under the Universal Health Coverage Scheme in 2018. It took us 14 years to introduce a genetic test to prevent an adverse reaction from a drug. And if we look at the overall odyssey of this policy introduction, we can do better by filling the gap of the policy inactivities. If we start the evidence building, health economics, guideline development, and the introduction to the universal health coverage at the same time, it is possible to introduce new technology within 2 to 3 years. So that is the main scheme that we use to introduce the Genomics Thailand scheme, Genomics Thailand National Collaborative Plan. And this National Collaborative Plan is lasting for 5 years. It began in 2020, finished in 2024, and it covering a lot of organization. At least 16 organizations is participating in this National Collaborative Plan. The Health System Research Institute, Department of Medical Science, Mahidol University, Faculty of Medicine, Ramatipudi Hospital, Faculty of Medicine, Sri Lat Hospital, Chulalongkorn University, Chiang Mai Medical University, Prince of Songkla University, and Khon Kaen University. So the National Science and Technology Development Agency, Thailand Center for Excellence in Life Science, the National Health Security Office, Medical Councils, National Research Council of Thailand, and Eastern Economic Corridor Office, they are all participating in this National Collaborative Plan. It began from June 2016. At that time, Professor Francis Collins visited Thailand for the reviewing of the USNIH activity. We met at the Mahidol University, and several funding agencies commit to fund the initiative for using genomics data in health system. In October 2017, the consortium was setting up, and in January 2018, Professor Eric Green was invited to Prince Mahidol Award Conference, which is happening every year. He presented the Human Genome Project as the awarded activities in the Prince Mahidol Award Conference. And many of the senior administrators from the Ministry of Public Health listened to Professor Eric Green lecture at the Ministry of Public Health, and the Ministry of Public Health learned about the usefulness of the Human Genome Projects and pharmacogenetics, infectious disease sequencing, the cancer and rare disease are the immediate benefit of the Human Genome Project that was introduced by Professor Eric Green at that time. And we have the Memorandum of Understanding signing on Genomics Thailand research, and we start drafting the National Strategic Plan on Genomics Thailand is from June 2018. It took us around 1 year. In January 2019, that the Prime Minister approved the National Priority Plans called Genomics Thailand, and it was sent to Cabinet approval on March 26, 2019. We have several follow-up workshops, and one of them is the Inception workshop in June 7th. So several ministers help us establish this national plan. Dr. Suwit Mesinsi, Professor Piesakon, and Professor Udom Kachinthorn. So they are all instrumental in pushing this plan through the cabinet. The plan is looking at incorporating the genomic information into the healthcare at all age group. We look at the premarital counseling, prenatal diagnosis, newborn screening, diagnosis and treatment of genetic disease, infectious disease sequencing, severe adverse drug reaction prevention, cancer diagnostics, hereditary cancer program, non-communicable disease, diabetes, coronary artery disease. And we would like to use the genetic information in all of this activity. We aim to be the Asian leader in genomic medicine within 5 years, allowing Thai people to have access to quality genomic medicine service. There are two main pillars, the research and application pillars and the clinical service pillar. Under the research and application, we developed the infrastructure for research, the Thailand Genome Database, the National Bioresource Center, and development of research platform and ecosystem. And for the clinical service, we will do technological assessment, the service improvement and quality assurance, also the planning of the service, establish the law and regulation, establish the clinical practice guidelines, pharmacy practice guidelines, research implementation guidelines, and this is supported by four overarching pillars: the data analysis and management, ethical, legal, and social implications, workforce development, and the promotion of new industry. These are the four infrastructure flagship projects. There will be genome sequencing laboratory. It will be the private entity that governments outsource the 25 million US dollar contract for 50,000 whole genome sequencing in the next 5 years. And we will get the FASTQ data from this genome sequencing laboratory. The data will be processed by the National Biobank of Thailand. They are the main entity for the data analysis. And they will establish the reference database for variant frequency in Thai populations. And the DNA sample will be processed at the National Bioresource Center. This is established in the municipal public health at the Department of Medical Science. We use the standardization, we use a standard sample collection and the DNA extraction protocol, and the centralized facility for medical sample repository. This includes the virus, bacteria, and other source of clinical biological sample. And to get the sample, we will establish we already established the clinical research unit across the hospitals in Thailand. This clinical research unit will taking care of the case recruitment with the unified protocol for consent and electronic questionnaire. We will return result and doing the genetic counseling, the pre-testing genetic counseling and post-testing genetic counseling. The project is going to be established for the population level reference genome database. This will be the long-term projects. At the moment, we have the 5 areas of research: cancer, rare disease, pharmacogenomics, disease-specific groups, and long-term and healthy population. This is more like a non-communicable disease groups. And for the service implementation, the Department of Medical Service will be the main organization for establish the guidelines, and National Health Security Office will look into the health economic evaluation, and the Department of Medical Science will look at the genetic testing service feasibility. We look at the possible technology for each national program. And this is the workflow of the main research project, the sequencing of the 50,000 Thai population from 5 diseases and 5 groups of diseases: rare disease, cancer, pharmacogenetics, non-communicable disease, infectious disease. So each disease has the research funding to get the sample, and if each research groups or each research plan need the spatial sequencing service, we would consider establish the common procurement protocol for that, such as the RNA sequencing or tumor sequencing or the infectious disease sequencing or bioinformatics analysis. Those that can be groups into a single activities. We try to make it more cost effective to do that. And the enrollment will be happen across hospital in Thailand, and right now we have around 24 enrollment centers. The research proposal was submitted for ethical approval, and several hospitals already have ethical approval to recruit the sample. The sample will be recruited. The individuals will be recruited, enrolled, counseling, and DNA sample will be sent to National Bioresource Center. We extract the DNA, send it to the genome sequencing laboratory. This center will be at the Burapha University because they already have the laboratory space, and the space for laboratory establishment will be used by the sequencing company. Sequencing company will do the sequencing activities and sending us the data. Burapha University is the government entities, so we will have control over the data flowing out of the genome sequencing laboratory. Once the data is generated, the data bank at the National Science and Technology Development Agency will manage the data. The data will be made available to academic researcher, training, and the commercial researcher. There will be a data access committee to looking at the research and development and human resource development for data utilization. The whole genome sequencing will be interpreted and reporting back to the hospital, and the data will be incorporating into the healthcare system. And eventually, we hope that the enrolling hospital can use the data as much as the patient consent us to use it. And this is the run by the Genomics Thailand steering committee and coordinating units and the research committee, research subcommittee in the Health System Research Institute. We are looking at the 3 to 5 years timeline of the key delivering results. Right now, Thailand is offering pharmacogenetic tests, HCB 1502, HCB 5801, and the Universal Health Coverage Scheme is underway for HCB 5801. This year, the reviewing process is finished, and we probably know whether the test will be universally accessible. And we have targeted therapy testing already available in the Ministry of Public Health. This test has already been introduced many years ago by the academic university team. And right now, the BRCA1/2 Lynch syndrome gene panel sequencing is already introduced by university testing laboratory. NIPT is accessible by the private hospitals and the out-of-pocket payment. And whole genome sequencing of Mycobacterium tuberculosis is part of the research program in the Ministry of Public Health. And we did the NAT2 genotyping as part of the research program. All of this will be evaluating by health economists, and once the health economists consider this service is feasible, we will determine the feasibility and introduce this service into the national program. Eventually, in the next 5 years, we may have the complete pharmacogenetics profiling, interpretation, and the universal access to the complete pharmacogenetic profiling and the thalassemia gene sequencing for many of the populations, and maybe the whole population sequencing for the thalassemia genes. So those are the genome testing service implementation that will be introduced in this national cooperative plan. The governance of this plan is under the Health System Research Institute. It was appointed by the cabinet as the secretary to this plan. And we have the research committee, the data committee, the ethical, legal, social implication committee, commercial development committee, and the service committee. So this committee is working together, and the first delivering project is the sequencing of the 50,000 population. And for pharmacogenomics, we will interpret all these 50,000 population pharmacogenetics variants and mutation, and we will looking at the functional study of these variants or mutations identified in these 50,000 populations. We also have the reviews on how to use the data to prevent the adverse drug reaction. So Stevens-Johnson syndrome and TENS and drug-induced liver injury will be the main adverse drug reaction that we tackle in the first phase of Genomics Thailand. And we also looking at the pharmacokinetics, pharmacogenetic study, and that is more advanced, and anti-tuberculosis PK PGX would be the first groups of research that may result in the improved outcome of the patients. So that is all that I would like to introduce to you. Thank you very much.